In Isaiah 40, verse 31, he says, "But they who wait for the Lord shall renew their strength. They shall mount up with wings like eagles. They shall run and not be weary. They shall walk and not faint." I know you're feeling overwhelmed, and this is all just really strange for us. But remember that God gives power to the faint. He increases our strength. Let's talk about the microbial diseases of the respiratory system that has nothing to do with bacterial pneumonia. Let's talk about tuberculosis. You notice your book says it's the leading killer in the world, and they're talking about a bacterial disease, heart disease, uh, and uh, and cancer in the first world countries or industrialized nations is the leading cause of death. Tuberculosis is a problem in the United States. There are strains of Mycobacterium tuberculosis that are antibiotic resistant. For many years, for decades, we didn't have any outbreaks of tuberculosis, but when the strain became antibiotic resistant, we started seeing problems. When we look at tuberculosis in the industrialized world, yeah, we don't see that many cases. But as people immigrate, they bring tuberculosis with them. A lot of times, people who are infected by tuberculosis bacteria aren't actually ill. They're asymptomatic, or they just have a real minor cough or fever, and they think that they have a cold. And most of us, our body does a really good job of protecting us. Basically, with Mycobacterium, remember that we did acid-fast stains on Mycobacterium smegmatis. And it's the mycolic acid that we're looking for. The problem with Mycobacterium is that it grows slow. And we stop and think about Streptococcus and Klebsiella and E. coli, and these bacteria just grow like crazy. But Mycobacterium grows slowly. So it kind of sneaks in. And then the mycolic acid and the waxy outer covering help protect the bacteria from phagocytosis. It invades a cell, the lung tissue, and it grows inside. It can also grow inside macrophages. And it is resistant to many drugs. So usually we have to give a drug cocktail. This is spread by inhalation of respiratory drops. You've probably seen in the cowboy movies or maybe in old-timey places that you visited that they have the spittoons. So where people, mainly men, who chewed tobacco or dipped had a place to spit instead of on the floor. And by spitting, then they released respiratory drops. And this caused a big outbreak in the Western United States of tuberculosis. This is why many towns, if not all towns, have laws on the books that you are not allowed to spit in public. You don't spit on the sidewalk because this was one way that tuberculosis could spread. So that's, spitting's a nasty habit anyway, but don't spit on the sidewalk. There are three types of tuberculosis: primary, secondary, and disseminated. Primary, secondary, and disseminated. So if we look at the pathogenesis, in primary, you see that it gets into the lungs. It's going to cause macrophages to come into the lungs, and it can be engulfed and killed by macrophages, or it can live in the macrophage um, and then go ahead and start replicating. So this can be a problem. The infected macrophages are going to present their antigens, the tuberculosis antigen, to the T cells. And then the T cells are going to produce lymphokines, and they're going to activate the macrophages to trigger inflammatory responses. And the macrophages will start to pack together, and they'll fuse together where you have these huge giant cells. That's what they're called, giant cells. Other cells are then, mainly the fibroblasts will come along, and they will deposit collagen and encase the macrophage ball, the tubercular, into really a prison. And then this will start to be calcified, and as it undergoes calcification, then we see that the macrophages on the inside begin to die, and it looks like cottage cheese. It's nasty. That's why they call it caseous. And right here, it can stop, or the mycobacterium can break free. Most of the time, this tubercle just stays in place, and our body deals with it. But if it breaks through, okay, if it breaks through the tubercle, then it can become activated and start killing more and more cells. And if it gets into the bloodstream, then it disseminates. And so it can go via the bloodstream, the lymph nodes. The macrophages can carry these, or the released bacteria themselves can go through this pathway, and then it can get into the bone marrow, the spleen, the kidneys, spinal cord, and the brain. And so a lot of people who have been exposed to tuberculosis stay in the primary stage, and but others, when their immune system weakens, can go into secondary and then into disseminated. So why do you think most of the deaths occur in Asia and Africa? I think it's, first of all, there's a lot of pollution. A lot of the people there are heavy cigarette smokers, so they already have damaged lungs, and of course they don't have proper health care. They don't have access to the antibiotics needed. If you've ever worked in a healthcare situation, or maybe in a food handling situation, you've had to take the tuberculin skin test. And basically what they do is inject some antigen underneath your skin, and if you have, after 3 days, if you've got a big whelp, they know that you've been exposed to tuberculosis, because your body has antibodies against that, excuse me, against the bacteria, and you've had an inflammatory response. Chest x-rays follow thereafter to see if there are any tubercles in your lungs. Like I said, it requires a cocktail of drugs to treat. There is a vaccine called BCG vaccine. The Soviet Union vaccinated everybody. It's about 66 to 70% effective. The United States doesn't require it because it doesn't reach the herd immunity efficacy. But if you've ever been vaccinated against it, then you will have a positive tuberculin skin test and you'll have to have a chest x-ray. So here we see a picture of the skin test, and you know, it's not very reactive at all. And then you can see in the chest, you can see the kind of the spots in the circle are the tubercles. All right, you might want to draw a line in your notes because we're going to talk about the flu. Okay, number one, influenza only affects the chest, the lungs. There's no such thing as the stomach flu. That's gastritis caused by, that's viral gastritis, or it could be a toxin, bacterial toxin. But most of the time, what we call the stomach flu, or yeah, no, that's not it. Not at all. There's influenza. We have pharyngitis, sore throat, congestion, cough, and myalgia. What is myalgia? This is muscle pain. If you've ever had the flu, then you are well aware of the muscle pain. There's a sudden fever, and you see this from the flu. The common cold, the fever kind of sneaks up on you. There are two major virus types, A and B. This is human, all right? And it's the mutations in the hemagglutinin and neuraminidase proteins that produce new strains. And this is caused by antigenic drift and antigenic shift. You need to write those words out and leave some space in between them in your notes because we're going to define them. So we have vaccines every year to fight what the CDC and World Health Organization think is going to be the strain that causes the biggest problems. 2008, we had kind of a novel strain go through the world. It was called H1N1. It killed thousands and thousands of people, but you didn't hear too much about it. The media didn't panic over it, and so we didn't hear much about it. But it actually killed more people in 2008 than the coronavirus has infected in 2020. Now, of course, we're just at the in between the beginning and the middle. We're about a quarter way through this pandemic. And so this novel coronavirus 19 may do a lot more damage. So let's look at what happens. So look at the virulence factors. All right, we have hemagglutinin and neuraminidase. You see these proteins sticking out like spikes. There's the envelope, and then inside, this is a negative single-stranded RNA molecule. You should note that with COVID-19, that is a positive strand RNA virus. So what do we know? Go back and review what we know about RNA viruses, how they replicate. This will help you understand why the influenza virus tends to mutate more rapidly than what we've seen of the coronaviruses, SARS, MERS, and COVID-19. So here's where I want to talk to you about antigenic drift versus antigenic shift. And I'll ask you questions about this on your exam. When we look at antigenic drift, write this down. Mutations and recombinations in the genes coding for HA, which is hemagglutinin, and NA, which is neuraminidase, spikes. So mutations and recombinations in the genes coding for HA and NA spikes are responsible for producing new strains of influenza A and B viruses in a process known as antigenic drift. So what we see is that in the host cell, the virus invades the host cell, mutation occurs during replication, okay? And then we have new viruses that differ slightly from the original virus come out of the cell, all right? So what are we seeing here? We're seeing mutations during replication. Mutations during replication from one type of the virus. What is antigenic shift? Okay, influenza A occurs about once every decade. Influenza B does not undergo antigenic shift. That's a good thing to remember. Influenza B does not undergo antigenic shift. So two different strains of influenza A enter the host cell. And while they're replicating, they exchange genes. All right? They exchange genes between each other. So they recombined. And since genes are changed, then you have different antigens. Because remember, antigens are going to be the products of the gene. So they recombined and into a new, a new strain of influenza A. And it is going to be very different from the original two viruses. So shift occurs when there's genetic recombination between two different strains of influenza A. Drift occurs when there's a strain and it has a few mutations, but it is slightly different from the original. Shift is when we have a new influenza virus A, which is very different from either of the original two viruses. We don't like shift. Drift we can handle. Shift causes major problems. So basically the virus invades the epithelium of the lung and undergoes lytic. Usually what happens is that patients can become susceptible to secondary bacterial infections. It depends on how severe the response is and if the patient is already immunocompromised. A lot of times infection provides not only immunologic protection, our body protects us not only from that particular strain, but strains that are very similar. Okay. Notice here it says, concern that changes in type A influenza viruses may cause another major pandemic. Well, it wasn't influenza A. It was coronavirus. So here we go. How do we diagnose? Signs and symptoms. Okay. We treat with supportive care. That's about all we can do. If you catch it early enough, some of these antiviral drugs may help, But the best thing to do is to get the vaccine. So it's really important that when the flu shots come out, that you go get your vaccination to protect yourself and to protect those who are vulnerable. All right, draw a line, take a break. When you come back, we'll talk about coronavirus respiratory syndromes. Okay? So coronavirus respiratory syndromes, at the time of the writing of the book, we had severe acute respiratory syndrome, SARS, and Middle East respiratory syndromes, MERS. Now you can add COVID-19, okay? COVID is coronavirus disease 2019. The 19 is for the year 2019. There's so much we don't know about this virus. Every day new information comes out. I would encourage you to go to the CDC or to the World Health Organization and read their updates. I think this would keep you at the front line of knowledge. There's a lot of false news, fake news. There are a lot of really stupid, treatments. Do not go to the sauna. That's not going to do anything. Yeah. But what do we see? So in SARS and MERS, and then we also see in COVID-19, high fever, shortness of breath, difficulty breathing. Now with COVID-19, we see a dry cough as part of the initial onset. So that's a little different. Patients will have not only dry cough, but they can develop pneumonia. And when you see it in the newspapers where they talk about, oh, this famous person died from complications of COVID-19, you can read that as pneumonia. Most of the people who are dying from the pneumonia. Remember that a lot of the people who are dying, not all, but a major number of them, already had lung disease, heart disease, and were immunocompromised. Some via diabetes, some were on transplant drugs, things like this. So the coronaviruses usually have very mild disease, but SARS, severe acute respiratory syndrome, Middle East respiratory syndrome, and now COVID-19 have higher fatalities. This is spread via respiratory droplets, sneeze, cough, and on fomites. What we see with COVID-19 is that it may also be airborne. In other words, it doesn't have to be in a moist environment in a droplet. We're diagnosing signs, symptoms, and we have, I read the FDA approved a 5-minute test to be used. In your virtual lab, you did the DNA analysis, and basically what they're doing is RNA analysis to see if you have the coronavirus RNA. Treatment is supportive. A lot of people have that developed the pneumonia have to go on ventilators, and right now there are no drugs to treat. There's some anecdotal information about a couple drugs, but it hasn't been tested. The French did a very fast run, testing run on about 20 patients, and some got better and some didn't. So medical science is doing all that it can. What we really need is a vaccine. Um, and it takes a while to get vaccines made and up and running. Go back and look in your book about how vaccines are made, and you'll understand why they're talking about 12 to 18 months. So we just have to do our best, esteem others more highly than ourselves, and uh, comply with social distancing, quarantine, washing your hands. Just do your best to stay safe. A very common childhood respiratory disease, and now we're seeing it even more in adults who are already immunocompromised, is called respiratory syncytial virus, RSV. Fever, runny nose, coughing, mild cold-like symptoms in older children and adults. Sometimes the young children, babies, have to be hospitalized so they can get treatments. The pathogen is the respiratory syncytial virus. Yay! They didn't give it a fancy name. It causes syncytia. What's syncytia? Well, that's like a layer of cells. You remember we looked at that pseudomembrane? That's a syncytia. Cells fuse together. They cover up the respiratory membrane, and that decreases the exchange of respiratory gases, and then we have major problems. Okay, this is just showing you a syncytia. So it's basically where cells fuse together. Transmission is close contact with infected persons. A little person sneezes in your face, thank you very much, or coughs in your face. It's prevalent in the United States. I don't know why it's more prevalent in the US than in other industrialized nations. Have no clue. Okay. Diagnosed by doing an immunoassay. Basically, they're looking for antibodies. Supportive treatment. And then how do you prevent this? You've got to clean everything. All right. So wash everything, especially in a daycare. They're working on a vaccine. What about other viral respiratory diseases? Children, elderly, immunocompromised. So these are people whose immune systems are not working at top notch. Cytomegalovirus, metapneumonia virus, and parainfluenza viruses. These can cause what we call the croup and viral pneumonia. And mainly these parainfluenza viruses are in young children. So, why do epidemiologists think that there will be a major flu pandemic in people caused by the bird influenza virus? Yeah, that may be next. Right now, we need to work on coronavirus. But why are they worried about birds? They're worried about birds, same reason that coronavirus is causing problems, COVID-19 is causing problems, is that this is a antigenic shift in which genes from another virus have recombined with a fairly common virus, and now we have a brand new virus that our population has never seen. And this is why we're really concerned about bird influenza, bats, yeah, whatever. Sheesh. Genetics. Everything's about genetics. Draw a line. and we're going to talk about fungus among us. Mainly, we don't see very many fungal pneumonia because our body does a real good job of killing off fungus, but anyone who's immunocompromised is going to be susceptible. And we have coccidioidomycosis. MYCOSIS means disease of fungus, blastomycosis, histoplasmosis, and pneumocystis pneumonia. Wow. Most of these we find thanks to our birdie friends. And so you see coccidioides, mainly along the Mexican-U.S. border in the southwest, certain places in South America. Blastomycosis is up and down the Mississippi and Ohio River Valley. And then histoplasmosis has a little bit wider spread worldwide, but we see it more in river valleys than in dry places. Okay, let's talk about pneumocystis pneumonia. So, difficulty breathing, anemia, hypoxia, and fever. Please note anemia. Okay, note anemia. It's caused by pneumocystis jirovecii, pneumocystis jirovecii. It's transmitted by inhaling droplets containing the fungus, and it is a very common disease among AIDS patients. Remember that AIDS patients have basically no immune system. So what you do is you look at the sputum, you look for little yeasty beasties, fungus among us. You can treat with trimethoprim and methoxazole. Wow. Best of our knowledge, you can't prevent infection unless you stay away from where it lives. So this is what the cyst looks like, okay, in lung tissue. So that's what the fungus does in lung tissue. That is not a healthy lung at all. Wow.